The webinar will start in 2 minutes. Welcome to the webinar, Clinical Guidance for Management of Newborn Hyperbilirubinemia, hosted by the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sherr, and I'm the Associate Dean here in the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. I'm speaking to you here today from the University of Alberta, and our buildings, labs, and research stations are primarily located on the territory of the Nahio, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as part of Treaties 6, 7, and 8, homeland of them and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. For a little bit of housekeeping for the webinar, if you have questions about technical difficulties or L3 programs and services, please use the chat function of the webinar. If you have questions for the speakers, please use the Q&A feature of the webinar on the bottom bar of your screen. Please review what's already been asked and upvote those questions you'd really like to have answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be sent via email to all of those who registered, and participants can claim CME credits and participate in personal learning development activity using the My L3 Plan tool. This is a free tool. For more information, please use the QR code on the screen. This activity has not been formally reviewed by the CFPC or Royal College, but it is eligible for non-certified credit. And Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. So today we're very pleased to welcome Dr. Jack Rabi and Dr. Kathleen Hicks, who will provide an update on the revised provincial guidance for the management of hyperbilirubinemia in infants 35 weeks gestation and beyond. Dr. Katie Hicks is a family physician and certified lactation consultant who's been working in Calgary and surrounding areas since 2015. She has an outpatient practice in Airdrie and focuses on prenatal, postpartum, and newborn care. Her inpatient work includes low-risk obstetrical practice at the Peter Lougheed Hospital in Calgary, where she also serves as the site lead for the section of maternal newborn care. And Dr. Jack Rabi joined the Calgary section of newborn critical care as a neonatologist in 2003. He's a professor of pediatrics at the Cummings School of Medicine and serves as deputy section head of newborn critical care in Calgary. His primary areas of interest are newborn resuscitation and hyperbilirubinemia. And working closely with the Child Health Program Improvement and Integration Network, or PIN, he has been active in this work. Both Drs. Hicks and Rabi are grateful for the opportunity to engage with so many valued stakeholders across Alberta to advance our management of jaundice in newborns. So thank you very much, everyone, for being here, and welcome. So with that, I'm going to turn it over to you, Jack and Katie, to share your slides. And I'm going to mute myself.
Thank you very much. Thank you for the introduction, and thank you to everyone who took the time to join us today. It's wonderful to see such a lovely turnout. It tells us that there is a lot of interest in this, and we appreciate that. So I figured we can start off by going over the outline of today's talk. So we will review the AAP 22 guidelines, which are the foundation on which we built this document. We'll talk about what's new, what has changed from the last guidelines. And then we want to be very frank and have an open discussion about potential challenges with the workflows, and then leave sufficient time for a group discussion. So the plan is to have this talk be 35 to 40 minutes, leaving hopefully enough time for us to have a good discussion and answer questions.
And Jack, have you shared your slides?
Oh,
We can't see them.
oh, I'm so sorry. I thought I had. Thank you for telling me. Let me see
No
here.
worries.
Let me go back to my Zoom. One sec. Zoom and share. There we go. And I will share my Microsoft PowerPoint.
Perfect.
Okay, there we go. All right. Oh, and let me minimize this. There we go. Okay, so how did we arrive here? Well, you may be aware that in the fall, we released another jaundice document, provincial document, supporting management of babies less than 35 weeks gestation, and that largely applied to inpatient population. And we decided to have two separate guidelines rather than one long guideline, which we felt would be unwieldy. So today we're going to be talking about the upcoming rollout on March 18th of the guidelines or the recommendations for greater than or equal to 35 weeks gestation in terms of jaundice management for the province. Both of these projects were approved for PIN support, and we are very grateful for that. As I said, the less than 35 week guidelines are already out there. And we are thankful for the support we receive from the Physician Learning Program to help roll this out. The reason we rolled this one out second is because it involves babies who are closer to term and hence will spend less time in hospital. It's a much more potentially complex workflow because now we have to consider babies at transitions of care, going from acute care to community care, to make sure we support them appropriately. That meant there were a lot more stakeholders that we had to engage, which was wonderful. And as I mentioned, transition to community guidance is included as well. Now, let's see. There we go. So what is the objective of the document? The objective is to reduce the incidence of severe hyperbilirubinemia and related consequences in newborns greater than or equal to 35 weeks gestation by, first, identifying newborns at risk for hyperbilirubinemia, identifying neonatal hyperbilirubinemia in a timely and accurate manner, providing timely interventions and or treatment as required, and ensuring appropriate follow-up in the community after discharge. So how did we approach the guidelines? As I said, we didn't want to combine the two guidelines. So today we're only going to be talking about the greater than or equal to 35 weeks. But I want to be clear, it would be lovely if we could have a single document that considered every potential clinical scenario for every potential gestational age that we might encounter and all the combinations and permutations of risk factors. However, that is beyond the mandate of what we set out to do, and it would result in a document that is quite unwieldy. And to give you an example, someone has actually done that work. The NICE group in the UK has done this work for the less than or equal to 35 weeks. And they produced what is considered currently the premier guidance for that age group. That document is 525 pages long. And of course, we have to think about our colleagues who might want to access this at 3 in the morning, and do they want to be flipping through 500 pages of background science? So we try to be mindful of what was included in the document. The other thing is we are very sensitive to the differences in local resources and the differences in culture that exist between rural and urban sites and across the province. And because of that, we stress that clinical judgment really needs to take precedence when deciding upon management. We appreciate that in some instances, it may not be feasible to implement what we are suggesting to the letter. And we have built some wiggle room into the guidance to allow for that, where we state clearly that we take into account local resources and local culture in terms of implementation. The AAP, one question you might have is, well, are we justified in making changes to guidelines that were put out by the American Academy of Pediatrics when implementing them, or should we implement them to the letter? The AAP actually was helpful and provided the following statement. The committee recommends caution and incorporation of local expertise in adapting these guidelines for use outside the United States. So in other words, they appreciate that if we're going to be using this in another setting, that we have to take local considerations into account in terms of how we implement this. So what is remaining the same? First of all, we continue to advocate for universal screening for newborns using either total serum bilirubin, that's TSB, or transcutaneous bilirubin, that's TCB. And the second thing that's not changed is we also advocate for continuing regular screening until the bilirubin level reaches a plateau. Screening helps determine the risk for newborn hyperbilirubinemia and facilitates effective early anticipatory management. What else is remaining the same? Well, this slide is specific to transcutaneous bilirubinometry, or TCB. So TCB is still a screening tool for hyperbilirubinemia. That's very important. It is not a diagnostic tool. So TCB is used to screen for the condition, but TCB does not determine the need for phototherapy or exchange transfusion. What TCB tells you is whether a total serum bilirubin is indicated. TCB level within 35 micromoles per liter of a phototherapy threshold requires confirmation with a total serum bilirubin to determine the need for treatment. Okay, and here's a quote from the AAP publication. Implementing universal TCB screening during the nursery stay and at subsequent public health nurse visits, that piece is very important, has been associated with a reduction in both blood draws and the likelihood of having a total serum bili level greater than 340, which is quite high. So what are the AAP guidelines? Well, they're created by the American Academy of Pediatrics. Our previous provincial guidance, well, it wasn't provincial, sorry, our previous guidance that we had at our various units were actually based on the 2004 AAP guidelines, which were the previous version. So we haven't had an update in 18 years. And these were published in September of 2022. Now, how did they go about coming up with the guidelines? Because if we're going to use this as a foundation, I think we should probably have some understanding of the pros and the cons of the document that we are using. They state that they incorporated new evidence published in the literature that came out since 2004, since the previous guidelines were out. But they are clear and forthright in stating that a large component of the document is based on expert guidance rather than objective evidence. And we know that expert guidance in terms of the hierarchy of levels of evidence is at the very bottom, but it is in some cases our only option. New evidence is insufficient to derive specific treatment thresholds. Explaining why they went with expert guidance on this point. And the committee actually started with the old guidelines and then tried to update them, but they used that as a starting point. For the 2022 document, they relied heavily on guidelines from the Northern California Neonatal Consortium and the Academy of Breastfeeding Medicine. What did they change in terms of their recommendations? Um, Perhaps the most important change is that the phototherapy thresholds were felt to be overly conservative when they looked at outcomes. And so they raised the phototherapy thresholds by, they said a narrow range, I would say a moderate range, that the committee considered to be safe. They revised the risk assessment approach based on the hour-specific bilirubin. I can tell you that that is an area that I think engendered a lot of confusion previously, was incorporation of risk assessment and how that influences our decisions and actions. I feel they've done a very good job with the new guidelines, and it's clearer. And they created this escalation of care pathway, which is intended to try and prevent a baby with a high bilirubin from reaching the threshold where they require an exchange transfusion. So that's the work they did. Now, as I had said before, we are basing these recommendations on the AAP 2022 guidelines. But it's not verbatim. And so we have had multiple discussions with many multidisciplinary stakeholders across the province, which has been amazing. And we've decided there are certain areas where we are justified in deviating from the guidelines. And I'm going to review those with you here, just in the event that someone actually reads the AAP 2022 guidelines and wonders why we're not following them to the letter in certain areas. So how do we decide when it is okay to alter the recommendation from Alberta? That's done based on our interpretation of the literature, but also based on local resources and workflows and feasibility. So one area where we differ is in the document, I have tried to place a lower priority for DAT testing in babies without hyperbilirubinemia. The document actually advocates for testing in asymptomatic newborns. However, I feel the literature is fairly clear that the performance of a DAT as a screening test is quite poor, and can actually lead you to be falsely confident in a false result. And we are advocating that a DAT is indeed appropriate, but not as a screening test. Rather, when you have a child with hyperbilirubinemia and you're unsure of the etiology, at that point, a DAT is an appropriate test. Another area where we differ is we place a lower priority on the utility of serum albumin as a risk factor. You know, this has been kind of the dream, is to have this marker of free albumin to guide our treatment decisions. But unfortunately, no such marker exists that's feasible to use clinically on a large scale. And so because we don't have a good marker, some people rely on just albumin as a surrogate marker. But multiple studies have shown it's a very poor predictor in terms of risk factors. Nevertheless, the AAP continues to advocate for it, and they state that an albumin less than 30 grams per liter is a neurotoxicity risk factor. We have left albumin in as an option for testing in certain places, and we've left it in the risk factors because we didn't feel that we were justified in changing those. And the other area we differ is I felt that the AAP document put too high of a priority on visual assessment of jaundice in the first 24 hours, when we have a multitude of evidence showing us just how poor we are at visually assessing jaundice. And so we continue to advocate for universal screening with TCB and or TSB if you don't have TCB available. Having said that, clinical judgment always rules the day. And if you have a child with visible jaundice that you are concerned about, then of course we advocate for further investigations. Other areas where we differ, the AAP document extends weeks beyond discharge from the hospital into community management. And that's beyond, again, the mandate of this guidance that we're providing. So we focused on the immediate period after discharge and how we can safely transition to the community. Another area where we differ, I suspect, is just due to a typo in the document. They state that you should stop phototherapy when the total serum bili has decreased by at least 35 micromoles per liter below the hour-specific threshold at the initiation of phototherapy, even though the baby is now maybe 24 hours older. So we have clarified that and stated that it actually doesn't relate to the initiation of phototherapy, but the baby's current age right now. One area that we're very excited about is we have reformatted the graphs and how the information is presented and how we interact with the graphs. And I'm going to show you some screenshots of that. Hopefully, it will make them more usable and more intuitive to use. And then the last area where we differ is, as this was a US document, there was some emphasis placed on home-based phototherapy. We don't have that as an option, as far as I'm aware, in Alberta, at least not widespread. And so the document does not include any mention of home-based phototherapy. Sorry, Katie, were you presenting this section, or was this me as well?
This particular slide was yours, but I can do it if you like.
Sure. Why don't you go? Thank you.
So we'll just switch gears a little bit into, who are we screening and how often we're doing the screening. So the criteria for using a TCB or a transcutaneous bilirubin would be if they're less than or equal to 10 days old. If they're in this guideline, if they're over or equal to 35 weeks gestation at birth. If they've now stopped phototherapy, so they've had phototherapy and now are past 24 hours after the phototherapy. So this is a definite change from the guidelines that we were using before, because we had always been using the guideline that said we can't use TCB anymore after a patient has had phototherapy. So if the phototherapy is past 24 hours now, TCB can be resumed for screening eligibility. And still in this guideline will be that the exchange, if they've had an exchange transfusion, we're not going to be going to TCB screening. Now, when we're screening, did you have anything else to add? Yeah. So when we're screening for hyperbilirubinemia, we always think about risk factors. Risk factors are really important because they help guide how often we're screening the babies for hyperbilirubinemia, and also what threshold we're going to treat them at. So this group of risk factors in itself is risk factors for developing hyperbilirubinemia itself. So those include, the things we're familiar with. So this isn't really new information, but a good review. So lower gestational age, and risk goes up as the gestational age gets lower. If they've had just jaundice in the first 24 hours after birth. Hemolysis from any cause, known or suspected. So if you're suspecting hemolysis, even if the cause is not known currently, that's still a risk factor for developing hyperbilirubinemia. If a family member has previously received phototherapy, if there's a family history of a genetic disorder like G6PD, if there's any scalp cephalhematomas, Down syndrome, a macrosomic infant of a diabetic mother, if the TCB or TSB before discharge was approaching the line for treatment, if they've had phototherapy, and of course, exclusive breastfeeding with suboptimal intake. So I think there was some discussion about that one when the guidelines were being written, in that we don't want to discourage exclusive breastfeeding. And one of the main tenets on the postpartum unit is to help with establishing breastfeeding. So it's not meant to discourage that at all, but more just to realize that exclusive breastfeeding is a risk factor for hyperbilirubinemia. So we have to make sure the intake is optimal. So the next group of risk factors are the neurotoxicity risk factors. So these risk factors, whereas the last group were the ones where we need to screen more frequently, these ones are actually the risk factors that make the baby more likely to develop neurological impairment. So these are the ones which would change the line in which you were treating to. So when you're moving down in the line and you're having to initiate phototherapy at a lower level, these are the risk factors which change the line. And you'll notice there's a little bit of overlap, of course. So gestational age less than 38 weeks is a risk factor for neurotoxicity. Hemolysis, that is known, so if including isoimmune hemolytic disease or G6PD. If the baby is septic, of course. And then the last one there, significant clinical instability in the previous 24 hours. So question mark, what is the actual definition of that? And of course, that's not something we can truly define. We know that we have to use our clinical judgment here. And you can use things like vital signs, feeding, baby behavior, hypoglycemia, those type of things would lead you to determine if they're at risk for this. And then at the bottom there, you can see the albumin. So I think Dr. Rabi already kind of addressed this, but it's still in the risk factors, but doesn't need to be checked in everyone and has questionable utility in the current system.
Excellent. Thank you, Katie. Fantastic. So how do these risk factors guide behavior? As Katie had mentioned, the hyperbilirubinemia risk factors indicate more frequent testing is needed, and the presence of hyperbilirubinemia neurotoxicity risk factors changes the threshold of action for phototherapy and exchange transfusion. And of course, we have to use the correct graph and threshold based on the risk factors. So this is what the original AAP graphs look like, and they're in the US imperial units, milligrams per deciliter. I just want to show you what the unedited graphs look like. This is not the version of the graphs we're going to be implementing. We do have an agreement with the AAP that allowed us to take this data and reformat it in a way that we thought was more meaningful for the clinician who's using Connect Care. I want to be clear about that. But as you can see, the original graphs had 6 lines, each line corresponding to a different week of gestation. And then they had 2 phototherapy graphs, one with hyperbilirubinemia neurotoxicity risk factors and one without. And then they had 2 more graphs for exchange transfusion thresholds with risk factors and without. The hyperbilirubinemia and neurotoxicity risk factors are incorporated into the graphs. We felt this would simplify the interpretation. I will show you some screenshots. Connect Care will automatically select the correct graph based on the baby's gestation. And the TCB and TSB data points will automatically be plotted, and there will on the same graphs, and there will be a legend so you can tell which is which. Just a note for nursing, the TCB data is entered manually using the Aegis POC module, and the TSB data flows automatically into Connect Care. The new graphs, one thing I'm very excited about, will show you the time periods when the baby received phototherapy and how much phototherapy they received. It occurred to us that when we're interacting with the graphs, if you don't know when the baby received phototherapy, it's hard to assess the response to the phototherapy. And we thought a simple visual cue on the graph itself would be clinically useful. And the other improvement that we made, which came again from consultation with our stakeholders, and I think this was a wonderful suggestion, was if you hover over a data point, it will automatically calculate and display how far away you are from the treatment threshold. And if you are above the treatment threshold, it'll show you what that is for each, for the risk factors. If you are above the treatment threshold, it will be highlighted in red to draw your attention. So this is a zoomed out version. I'm going to show you a zoomed in version. But what I want to show you here is now we no longer have those 6 different gestations on each graph. This baby in this example is 39 weeks. The 39-week AAP 2022 graph is automatically selected and the data is plotted on it. You can see that this, let me zoom in now so you can see a little closer. You can see that this baby received phototherapy starting here and ending here, and that allows you to see what kind of response you had to the phototherapy. And you can also see that both the TCB data here in blue and the TSB data in purple are displayed on the same graph. And if you hover over a data point, it will show you what the actual value is, as well as the thresholds for exchange transfusion and phototherapy based on the presence of risk factors. And you can see in this example, this baby at this point would be above the threshold for phototherapy. So it's highlighted in red, and it calculates it and tells you, okay, you're 13 above the threshold. Our users who are familiar with current guidance that we have are probably very familiar with this graph here, which was advocated for by the Canadian Pediatric Society and is taken from the AAP 2004 guidelines. So we're simply going from a graph that looks like this to several graphs that look like this. Katie, did you want to speak on the escalation of care pathway?
I can. So what we need to know is, I think the point of this escalation of care pathway is to try and avoid exchange transfusion, essentially. So in order to do that, it's good to have a plan of how to sort of the pathway to go by to avoid this. So usually you notice this when there's is sort of triggered by an elevated or rapidly increasing bilirubin. So in that case, they may be admitted to the NICU. You're going to have a stat total and direct, serum bilirubin, some other blood work, and a TSB at least every 2 hours. And then the escalation of care pathway happens once the threshold of 35 micromoles per liter below the exchange transfusion is reached. I'm not sure if you had any more things to say.
That was perfect. Thank you, Katie. I appreciate it. Wonderful. Okay, next I wanted to talk about how we check irradiance because, again, through our wonderful meetings with our stakeholders, this was an issue that came up repeatedly, and that is how do we check that we are delivering the right dose of phototherapy to our babies? So the first point is that we should check the spectral irradiance of phototherapy equipment with an appropriate irradiance meter. And that's the key word there, is appropriate. And that means an irradiance meter that has been approved by the manufacturer of the phototherapy device. When this came to our attention, we worked to release a provincial safety notice, which came out last year to make everyone aware of this. We also undertook work to document all of the equipment available across the province, including who had what lights and who had what meters, and we've created in an appendix in the document that shows you which meters are approved for which phototherapy devices. Okay, but what we did learn is that the irradiance meters are not interchangeable, and this is a source of frustration for people because it seems irrational. All we're doing is measuring light intensity. Why should the light meter matter? That certainly was my thought at first, until we dug into it a little bit and learned that each light meter from each manufacturer is tuned to be sensitive to a different spectral irradiance, so different frequency. And hence, if you use two different meters on the same baby under the same light, you will get two different numbers. And that is intended by the manufacturers. And then they have recommended targets based on their meters. We won't go through this line by line here, but there is a pathway for getting ready for discharge for babies who did not receive phototherapy during their initial stay. So some guidance around that. And similarly, there's also guidance preparing for discharge for babies who did get phototherapy during their stay. And this refers to what is the risk factor for a baby having rebound hyperbilirubinemia if they had received phototherapy during their initial hospital stay. And the literature shows that risk sits somewhere between 5% and 25%. But the risk factors are less than 48 hours at the start of phototherapy, the presence of hemolytic disease, gestational age less than 38 weeks, and a higher total serum bilirubin at the time of photo discontinuation in relation to the photo threshold. So basically meaning that your TSB was close to the line when you stopped the phototherapy. The AAP, in terms of, we're going to shift now to talk a little more about preparing for discharge, and I'll hand it back to Katie in a second. The AAP was clear that a system, this is quoted verbatim, a system should be in place to provide care whenever there is uncertainty regarding the provision of appropriate follow-up. This care includes a mechanism for providing the results of any testing to families and providing care according to these guidelines. So, Katie, I'll hand it back to you in terms of getting ready for discharge.
Yeah, so along with making sure that we have a good plan for follow-up after discharge, and making sure that whoever is thinking that the baby needs follow-up or further testing has confirmation that that's going to be done by somebody in the community, or they plan on doing it themselves. As well, we have to prepare the families for discharge as well, so they're aware of what we recommend for testing, what to watch out for in their baby, and how closely they need follow-up.
Excellent. Thank you, Katie. I'd like to take a moment too to acknowledge the critical role of public health in safely transitioning our babies to the community. They really are a program pillar. We couldn't do this without their tremendous contributions. They have a greater than 90% follow-up rate after discharge. It's somewhere between 90 and 98%. But we do acknowledge that public health nurse resources differ across the province. There's differences in access to TCB meters and differences in ability to collect lab specimens depending on where the patient is discharged home to. We'd also like to acknowledge our midwifery colleagues as well, who have an important role to play here. And this refers specifically to infants born outside of the hospital. But of course, acknowledge that midwifery is also involved in the acute care phase for babies that are in hospital as well. Infants born at home should have bilirubin testing between 1 to 2 days after birth. Close follow-up with home visits during the first week after birth occur, and babies will be assessed within 1 to 2 days of discharge from hospital. Important to acknowledge that methods of quantitative bilirubin assessment, so TCB or TSB, will vary by community. And midwives often collect total serum bilirubin and or DAT specimens during visits with clients, which is fantastic. And they may collaborate with local public health and outpatient labs to ensure timely follow-up of bilirubin levels. So what is new? We're kind of getting into the summary here. What is new? First thing is, once the new guidelines come out, we will be able to resume TCB screening 24 hours after phototherapy has stopped. which is wonderful. Hopefully save some pokes. There's a new approach to risk factors, with one being risk factors for hyperbilirubinemia and the other one being risk factors for hyperbilirubinemia neurotoxicity. The phototherapy thresholds have been raised, and there are new graphs. So what are we looking to in the future? First off, we have planned ongoing surveillance and have partners in the province who are going to help us with that in terms of conducting a planned formal assessment after 24 months. It will seek end user and family feedback. We'll be looking at clinical effectiveness and looking at cost. And one of the areas we're interested in is looking at how RNs and LPNs manage interpreting the graphs and what workflows work for notifying the MRHP. The other thing that we're excited about for the future is ongoing optimization activities. And in anticipation of this launching in March, we've already begun some optimization work. So for example, continue to work on increasing the functionality of bilirubin graphs. We showed you how we're going to be displaying the phototherapy epochs and the delta from the treatment threshold. Another important thing for the graphs, Katie actually raised, was we have many colleagues who work outside of acute care settings in offices, and they may not have ready access to Connect Care, and they often interact with these graphs by having them printed off and put in their office on the wall. So is that something that we can accommodate? So we're going to do some work on that as well. One big area that I'm excited about is we've been working for over a year now on a Connect Care solution to facilitate acute care physicians or acute care clinicians tracking patients after they have been discharged to the patients so that they can ensure that the testing was done and review the results. We advocate for that, but we didn't really provide a tool for doing that. So I'm cautiously optimistic that we're getting close to a solution for that. Always being mindful of resource inequity across the province and how we can mitigate that and hopefully reduce inequities. And then doing some work to see if we can align our spectral irradiance meters and how we utilize them, because I must admit that whole manufacturer-specific meter thing is rather frustrating. So what are the challenges? We need to be mindful of what challenges we're facing. So we did have the staggered rollout, right? And I was a little concerned about the potential for confusion between the two guidelines coming out, but I have to say, based on the feedback we've received, things so far have gone pretty smoothly. So we're happy with that. But with this new guidelines, we acknowledge that we have a lot more stakeholders. We have a more complex workflow and very important community involvement. Areas where there's ongoing potential for confusion. In Calgary, we have our own TCB graphs based on our lab performance locally. And so those will continue to be used, and they'll be clearly labeled as YYC TCB graphs. When we reviewed this, we felt that continuing to use these graphs did not significantly increase the risk for patient harm, but it did potentially increase the risk for health care provider confusion or frustration. So we tried to be very clear about that in the guidance document. And then I think this is the second last slide. What are the challenges in Alberta that we've anticipate based on user feedback? Well, one of the things is, there's a recommendation in there that once you start phototherapy, you really should check with a total serum bilirubin within 12 hours to document a mid-therapy decline. We received significant pushback, mainly from physicians some who felt that perhaps this was a little bit overly prescriptive and that 12 hours might be too soon and not necessary. And I can certainly see instances when that would be the case. And that's why we were sure to include language that allows you to deviate from this if you feel you're clinically justified in doing so. The other one is we wish to discourage people from ordering a total serum bilirubin automatically in the absence of ordering a TCB if available, because the infant is considered higher risk. TCB should still be the initial screening test if available to you. And then, of course, as we mentioned, inequity in resource distribution. So with that, I'll just want to end by saying thank you from Katie and myself. We want to acknowledge and thank the Child Health PIN for their tremendous support. And I have to call out Pamela and Christine, who have taken very good care of me and really were the drivers behind making sure this went smoothly. Also, a big thank you to the Physician Learning Program for helping us get the word out. And then our many multidisciplinary provincial stakeholders that include nurses and nurse educators and patient care managers and unit managers, physicians in the community and the hospital, our lab partners, our partners in public health, in our midwives, and our Connect Care team, which has been very helpful in getting this up and running. So with that, we'll close out the talk and open it up for questions.
Awesome. Thank you so much, Katie, Jack. We have a lot of questions in the Q&A. Just to share with those who joined later, please use the Q&A feature for your questions, and have a look and upvote questions if yours is similar. So just to start with Amanda's question, Amanda Phillips, will the guidelines be the same for infants not yet discharged and those who are returning to the emergency for jaundice? Currently, there's 2 different guidelines being used in central zone and rural.
Wow, what a great question. So the guideline that is coming on March 18th, we have actually incorporated a section into that guideline that talks about what do you do when you readmit a baby to the hospital for phototherapy, and how should you manage that baby? So yes, the new guidelines will cover that topic.
Okay, great. Amanda, I'm going to complete this. So if there's follow-on, please just repost. And Megan's asking whether or not with the new graphs, there'll be downtime copies available, and what the maximum number of hours old that will show up on the graphs.
Oh yeah. Oh wow. Such insightful questions. So yes, so the plan would be to have a downtime procedure where the graphs would be available. However, Pamela, I'm going to ask you to put a little asterisk by that, and we can discuss it when we meet tomorrow, just to confirm that that is the case. But that should be the case. That's for sure. That was the first question. Sorry, what was the second part of the question?
Oh, I just completed it. Sorry.
I'm so sorry.
It was, she was just sharing that currently there's 2 different guidelines being used between central zone and rural. So maybe potential for a bit of confusion if those aren't aligned with the new guidance.
Okay. Well, this single document should replace those.
Okay, perfect.
Yeah, yeah.
And Jeannie has a question about whether you could review when TCB and TSB need to be repeated after phototherapy has been initiated, and when the follow-up testing should be done after the phototherapy has been given.
Right. So in general, TCB can be reinitiated. Oh no, I just remembered the second part of the question from the last question, that she was asking how long do the graphs extend out to? That's what you want to know. Yeah. So sorry, let me just address that quickly. So the graphs from the AAP extend out to 14 days. The interesting thing, if you look at it, and again, this speaks to the nature of the data that the graphs were built on. You'll see over the first 3 days, the graphs have a slope and it's kind of slope upwards. And then by day 3, they level out and they're horizontal for the next 11 days. I think we'd all agree that physiology doesn't work that way, and that is more a reflection of our lack of knowledge of the data. And so I'm always a little skeptical about, the farther out you get, how accurate is this? But nevertheless, the AAP provided it for 14 days out, and that's how they're built into Connect Care.
Okay.
Okay.
Great.
And then the next question, I'm sorry.
But on repetition of the TCB or TSB after you initiate phototherapy, and then after you're done with phototherapy.
Right. Thank you. So TCB can be reinitiated as long as you have waited 24 hours following uh, stopping phototherapy. And we recommend testing from the same site that you were testing at before. So, the two sites we recommend are the forehead and the sternum. If you were using the forehead before, we recommend you return to using the forehead if that is still an option. As for the TSB and how we use that, it's recommended that once you start phototherapy, because you can no longer use TCB while a baby is under phototherapy, that you check with a TSB no more than 12 hours after starting phototherapy to indeed document if the baby is responding as intended. That is one of those pain points that I had mentioned earlier that we're going to be keeping a close eye on to see how people manage that. And then in terms of when do you stop? You stop once you have dropped below the phototherapy threshold by at least 35 micromoles per liter. And you'll see as you read through the document, most of the decision points are based on a delta of 35. So usually if you're 35 within an action line, that tells you that you should be thinking about risk factors or a change in approach. So the recommendation is once you have dropped 35 below the phototherapy treatment threshold, then it would be reasonable to stop phototherapy at that point.
Okay. So Dr. Al-Masawi is asking, can a TCB close to the threshold or trending up generate an automatic order in Connect Care to minimize workload on physicians and prevent delays in waiting for an order? He thinks this could be very important for smaller centers and hospitals and might address your notion around timing.
Yeah, I mean, it's a lovely idea. I mean, what we're talking about here is having the system, in other words, Connect Care, actually make a treatment decision, looking at the TCB and then deciding if the patient should have a TSB. I mean, it sounds lovely if we can get that to work. I'm a little skeptical that we're at the point where we can do so safely, but that's certainly something that we can keep in mind for future optimization work.
I know the PIN's really interested in using AI for a lot of those things, so sounds like something that could be thought of.
Yeah.
So Jen Collins was just asking for clarity on whether the graphs also show the distance below the threshold. And I think they did, based on
Yes,
risk factors and without, based on the screenshot you showed, yeah?
that's correct. They will calculate the delta from the line. So if you're above the line, they'll show you how far above the line you are. And if you're below the line, they will also calculate how far below the line you are.
Mm-hmm. And Christopher is asking, what happens if the clinician feels that the gestational age is inconsistent with the physical exam? So, will the phototherapy curve, which would be used, or presumably could you modify it?
Yeah, absolutely. Again, clinical judgment rules the day. If you have assessed on your, clinical assessment that the gestational age is actually should be modified, I would assume that would apply to all aspects of the baby's care, including how you manage jaundice. So I would say that the gestational age should be based on your assessment as to what the best estimate of gestational age is.
Mm-hmm. And Daniel's wondering about whether or not we have numbers on how many babies in Alberta have been affected by acute versus chronic hyperbilirubinemia and encephalopathy in the last 5 years.
My goodness, these are great questions. When we started this work over 2 years ago, that is one of the things that we actually looked at. And we ran a query to see, and I think we ran into a coding issue. Because you would think that we had a pandemic of kernicterus in Alberta based on the numbers that we had. And it just didn't seem to reflect reality at all. So this next go around, we're going to be paying closer attention to how that search is conducted. The problem is it's very labor intensive because it requires confirmation by going back to the original chart as well. And when we did that with the initial run, we found that the vast majority of those cases that were labeled as kernicterus actually didn't have anything else in the chart to indicate that that was in fact correct. We think it was just miscoded. So yes, we do intend to look and to continue looking, and we have looked, but I just want to be honest about some of the challenges in terms of drawing some meaningful conclusions from the data.
Mm-hmm. And a related question that I think is from Valerie Lewis, who's asking, there's been some changes to getting newborn data, and is there or will there be data on incidence going forward of hyperbilirubinemia phototherapy? So, maybe helping with those issues you were just referring to in your answer to Daniel's question.
Yeah, I mean, I think you're really speaking to something I'm excited about here, and that is there a way for us to have a real-time surveillance tool, a monitoring tool to let us know how we're doing? And that would be something like a dashboard that we could potentially build in Connect Care going forward. And I think once we roll this out and the dust has settled, that is something that I certainly would like to explore for optimization.
And then there's a bunch of questions related more to the community angle that I'm going to try to group together. So Brianne's asking for community providers, including midwives, is there going to be access to these graphs without logging into Connect Care each time? Wondering about things like access on the Epic phone apps.
Oh, interesting. I'll tell you when we built the graphs out in Connect Care, we had to get the approval of the AAP, and I believe we signed a contract with them. We are actually meeting tomorrow, and one of the agenda items for discussion tomorrow with the PIN is if our contract allows us to print off and provide paper copies, because that's certainly something we would like. Actually, one of the great things about working with Katie is I got the perspective of working in the community, and Katie let me know that a lot of community offices, you may not access Connect Care, and you may prefer to have a graph that you just have taped to the wall. And so we're going to be discussing that tomorrow. And certainly the intention is, yes, to make those available. We just have to make sure we're crossing all our T's and dotting our I's. Okay.
And Heidi is asking, sort of highlighting those variability on equipment and sharing that Okotoks and Airdrie don't actually have TCB machines.
Yes.
And so is there a parallel strategy with this to try to look at access to equipment?
Absolutely. In a word, yes. The mandate that we had was to create a guideline for the province to kind of streamline and align treatment. But inevitably, when you do that, you become aware of the inequities. Now, what we will do is we will, to the best of our ability, advocate for centers that don't have TCB to get TCB, but that really is beyond the official position that we have. And so I mentioned that because I don't know how much weight it will carry, but that doesn't mean we're not going to try. We're going to try to advocate and hopefully get some traction.
And related, are there concerns with regards to the accuracy of TCB in darker skin tones?
Oh my goodness. Someone's been reading the literature. That's wonderful. Yes, there are concerns. And what we have seen is that babies with darker skin tones tend to have falsely high readings. And you know what? This is something that is coming out across medicine. It's been shown for pulse oximetry as well. But just sticking with TCB, yes, babies with darker skin tones tend to have falsely high readings, which means that they will unnecessarily get more blood tests and pokes. And I've actually reached out to the AAP and asked about, how can we try to address this? Is there, perhaps a fudge factor that we should consider? And it's a real challenge because We don't have a reliable way of assessing skin tone that is readily available to us. I'll let you in on a little secret. The way we determine if a baby is light, medium, or dark skinned is based on color swatches that we obtained from a cosmetics company for blush. Because we knew that that was going to be consistent over time. But the real test actually involves dedicated equipment. And last I looked into it, they were many tens of thousands of dollars and not particularly portable. So we don't have a good objective measure of measuring skin tone, but we know that in general, babies with darker skin tones do tend to read falsely high. Now, can we do anything to mitigate them getting unnecessary pokes? What we recommend in the guideline, specifically, we address that point. And we say that, you know, if you have a baby who has had, regardless of their skin tone, if you have a baby who has had 2 consecutive falsely high TCB readings that resulted in TSBs being drawn that in hindsight now were inappropriate, that it is reasonable at that point to stop using the TCB meter and continue on with TSB testing as clinically indicated. We're not suggesting you do daily TSB screening in that situation, but rather that you switch your approach at that point and use TSB as you think it is clinically indicated.
Mm-hmm. And Naha had a related question around whether there's a study to check TCB at areas like nasal bridge at a specific location.
Yeah. We have actually done some of that work in Calgary, and there are publications looking at different sites for testing. The nasal bridge is certainly one option. We're a little concerned about putting a device on the nasal bridge, just given the proximity to the eyes and the potential for it slipping. I personally prefer the forehead because it provides a nice flat surface. I found, and the sternum is appropriate as well. But I found with the sternum, sometimes it can be a little harder to get the probe completely flush, especially if you have a baby who's a little growth restricted and their ribs are sticking out, and that'll give you a falsely low reading. I guess if I had to summarize the data, it shows that regardless of what site you pick, it should be fine as long as you consistently use that site. And the reason for that is jaundice physiologically progresses in a cephalocaudal direction. So the jaundice levels naturally will be highest in the head and lowest in the feet. They kind of progress from the head downwards. And that's why we say, all the sites are okay, but just please continue to use the 2 sites. And the guideline that we wrote specifically advocates for forehead and sternum.
Mm-hmm. And Dr. Apostol is just making a note that here in Edmonton zone, TCB screening and follow-up are not available in the community, so TSB will be used until TCB machines are available here.
Yeah, in the community. That's right, absolutely. And one of the other things I will mention about our friends in the North Zone is public health there actually has the ability to decide on when to draw a TSB and to actually order that TSB to be drawn. That is not the case in the South. So both, wherever you go throughout the province, you see some things that you would like to have locally and don't have, and other things that perhaps you have that your colleagues don't have. And hopefully over time, we'll be able to get some equity there. But I can tell you, we have spent a lot of time meeting with our friends in public health, and they have significant challenges in terms of resource utilization. And that's why there are differences in what they can do across the province. The hope obviously would be that we would have the same resources available across the province, but that's something in reality that we need to work towards, but we just don't have currently.
Okay. There's a bunch of related questions to that around processes. And I think you were speaking about implementation, but Jackie Andreas was sort of highlighting, when there would be guidance for public health nurses as to when to consult a physician or book follow-up assessments. And so it seems as though, there's timing in the previous guidelines around when based on risk factors, et cetera, that these things should be booked, and that there's some discrepancy with the guidelines. So can you comment on guidance specifically for public health around?
Yeah, yeah. Thank you for asking that question. When we launched our previous version of this many years ago, we didn't have the support of the PIN. And one of the areas that I realized I fell short on was really incorporating the work of public health into the document, providing some guidance. We were not going to make that same mistake a second time. So we engaged our colleagues in public health right from the very first step. And they were involved in approving the guidance that we have. And we actually took some of their recommendations word for word and cut and pasted them into the document. So this document actually has a dedicated section to public health and how we can support our public health colleagues. And an example of that is, I know one of the major pain points I've heard from our public health colleagues is, a baby going home on a weekend without an order for a TSB. And they're left scrambling, trying to find someone who will order it and then someone who they can talk to about interpreting it. And that is something we didn't want to repeat. So we have gone the extra step in this guideline to provide clear guidance around the role of the acute care physician and what they can do around the time of discharge to make sure that we're not inadvertently creating a headache for our public health colleagues after the baby goes home.
Mm-hmm. Yeah, perfect. I'm mindful of time. There's a number of little comments in the chart, questions in the chart as well. Pamela, maybe we can note those down.
Yeah.
But there's several that relate to the graph, whether a graph should be used if a baby's born at 36 and is less than a week old. Should they follow the 36 or the 37 process questions, etc., which I think all could be very useful for questions for your implementation. Some of them are reflecting things you commented on in
Wonderful.
the task, and has highlighting again that confusion potentially with the Calgary guidelines on insight, and so
Yeah.
being clear of some of those elements. So I think this gives some insight. Angela had a question about the risk factors for rebound phototherapy, but you revisited that later in the talk. So I think that was quite clear. So that was posted right away at the beginning. Okay, so I think in the interest of time and getting everybody off to clinic, we should probably wrap it here. But if you have additional questions, please send them along and we'll forward them to the speakers. We will be sending out that recording and some pearls in a week or so. And feel free. I mean, I think this is a dialogue, so please send questions in, and I think that'll inform the implementation of this work, Jack. And just, I think I want to echo in the chat, one of the colleagues had Heather Wanjala had highlighted that this really seems like a comprehensive guideline that will help prevent unnecessary or excessive use of phototherapy, and that there's benefits to doing that. So I think kudos on that. But there's a little bit of questions as well in the chat as well that we should catch for you, Pamela, just to make sure that the guidance, maybe a Q&A sheet to go with the guidance, just to address some of these common questions might be a helpful thing for the implementation. And thanks to everybody who's attended and to the speakers. It's just been great. Thank you so much for all the hard work on this. And
Thank you.